So we good to go?
Yes. Good morning, everyone. My name is Nana Saib. I'm General Manager Sales, MPure Pharmaceuticals. I welcome all of you, all the Eastern faculties and delegates for today's one of the most important iron dialogue session, which is focused on anemia and iron deficiency. And one of the leading cardiologists from Pune and Maharashtra will be part of this. And let me tell you, more than 340 doctors have joined us on the Zoom platform, webinar platform all over India, briefly from the Maharashtra. I request our coach director, Dr. Sunil Sate sir, to come on the dais, and I request BDM Sandeep Godse to felicitate Dr. Sunil Sate. I request Sate sir to proceed the session.
Joined. I think without delay, we'll start this session on focus on anemia. We have three interesting talks. The first is by eminent hematologist Dr. Bhave from Mumbai. Second, I'll be speaking, and third, we have a talk on anemia and security by Dr. Dighe. I'll first invite Dr. Ramanan, very senior and experienced hematologist from Pune. He's at Ruby Hall and many other centers, but extremely good academician. And I would request him to take over the session. Dr. Ramanan, please.
My pleasure to introduce my senior from then went for advanced training in hematology at Vellore, and then at Westmead in Australia, and in Muscat with our teacher, Dr. Maman, and he was instrumental in setting up the transplant. FRCPA from Australia. He's a member of the ICMR task force for national guidelines on myelodysplastic syndrome, for DVT, and for neuroanticoagulant. He's a member of the board for studies of IMU Mumbai West. He's got many awards, many papers, and he's been dealing with very complex cases in hematology. We have been referring patients to him. It's a pleasure to, in fact, invite him for this lecture on practical tips in iron deficiency. So I hand over the stage to Dr. Abhay Bhave for the first.
Thank you very much, Vijay. I'm sorry, some of the words didn't come through because the network is not very good, but thank you for the introduction. And the topic that has been given to me, and I would like to share my slides, is on a practical approach to anemia. And I'm going to highlight iron deficiency anemia as the front runner, but I'm going to give you an overview on anemia as such. If you look at the theme of today's events, it's on anemia and how it impacts the different organs, but I thought I'll give an overview. So when we talk of anemia, an means without, aima is blood in the Greek language. Anemia means actually without blood. It's a quantitative or a qualitative or a combination reduction in hemoglobin and red cell count in a patient. For a male, we do not know the range of normal hemoglobin in our country, but from the Western statistics, it is 14 to 18 for a male and 12 to 16 for a female. So technically speaking, below 14 for a male and below 12 for a female is looked at suspiciously for anemia. Now, the issue is, why diagnose anemia? Do we need to diagnose in the first place? So it can vary from a benign to a malignant condition. And that's why it is extremely essential that we diagnose anemia. Here we have something called as cause and effect. So if you were to see, technically speaking, anemia is an event, and sometimes it might be an iceberg phenomenon. We don't know what is hidden below. And the etiology is the one which is actually causing the anemia. So I don't like it when my residents write the diagnosis as iron deficiency anemia or anemia, because that's an event. It's a front runner. We have to find the cause. And this is something which anemia is something which affects the quality or the health related quality of life of a patient. So let's understand how anemia can occur. So if you look at from point, so if you look at from here to here, this is all inside the bone marrow. We've got the stem cell, which makes the burst forming unit erythroid, colony forming units erythroid, the erythroblasts, which then mature, become retic, and retic becomes the red cell. They are the ones which we see in the peripheral blood. We see some retics in the blood and in the bone marrow. So essentially, most of the journey of the red cell in its precursor form is inside the marrow. So anemia can be as part of this part of the bone marrow getting affected, like pure red cell aplasia, PNH, anemia of chronic disease, nutritional anemias, especially B12, can affect the stem cell. And as we go more peripherally, it can be breakdown of blood, that is hemolysis. It can be blood loss anemia, either from the GI tract, from menstruation, or it can be an underlying malignancy. So you've got a plethora of reasons why anemia can occur in one particular person. And therefore, it's extremely important to have an approach, and that to a stepwise approach. So if you look at this clinical journey of a patient who has got anemia, it's important for us to take a good history for the signs, for the symptoms, and then do a good clinical examination. Look at the lab parameters, and then put these two together for what we call as a CPC, or clinical path correlation, so that we are empowered with the knowledge of this patient so that we can come across a diagnosis, and then we will treat. So there is no shortcut to treatment. If we don't understand pathophysiology, we are unlikely going to be able to treat the patient effectively. And sometimes, despite this approach, you will find that we are going in circles, we don't get an answer. And it's sometimes then becomes very important to review all our tests, maybe re-perform some of them, and take more opinions to see that we get the right diagnosis. So if you look at the history, I think importantly, if a patient has got leg cramps, fatigue, irritability, excess bleeding during menstruation, GI blood loss, as in hematemesis or in piles bleeding, then we are always worried that these are all the front runners to anemia. But if they start getting constitutional symptoms along with that, such as fever, weight loss, night sweats, itching on the body, it's always worrisome for an underlying malignancy. Clinical examination usually reveals pallor, and you should look for icterus, because if there is hemolysis, icterus takes place, and that augurs a differential which is not like that of iron deficiency or B12 deficiency. And to add to that, if they have got lymphadenopathy, organomegaly, or hemodynamic compromise, or signs of cardiac failure, we again know that this anemia is not good for the patient. We should look at the duration of anemia, try to get all the old past records and review it. Is the anemia now, or is it there from before? Because there are some conditions like thalassemia where the hemoglobin will always be low from the beginning. And therefore, it's important to just review all this data of the past before we come to a firm diagnosis. Also, reviewing what the family history is. Sometimes there are other members of the family who have a low hemoglobin, and that could also help you to decide on the level of aggression and the type of investigation that you have to do. So what's my starting point for diagnosing anemia? Or what's my approach to anemia? So we must insist on a automated CBC, which gives you several parameters, such as the hemoglobin, which is a quantity, a white cell count, which is a quantity, and a platelet count, which is a quantity. Now, to this quantity comes a quality. So you can have a hypochromic microcytic anemia, or a macrocytic anemia, or a normochromic normocytic anemia. So also with the differential count of WBC, you can have a neutrophilic leukocytosis, lymphocytic leukocytosis. You can have a neutropenia, lymphopenia. So it tells you the quality to that quantity. And based on a CBC, which comes from an automated method, we've got certain parameters which have been calculated, either derived from the machine, that gives you as reference ranges, which I'm showing you over here. Now, based on this, we come to certain understanding of what's happening to the patient's hemoglobin and its associated parameters, which are called the red cell indices. So then we classify on the basis of these anemia, of this CBC, what type of anemia the patient may be having. So we look at the MCV, mean corpuscular volume, that is the size of the red cells, and the mean corpuscular hemoglobin, which is the amount of hemoglobin in the cell. If both are low, it is called hypomicroanemia, hypochromic microcytic. If both are normal, it's called normochromic normocytic anemia. And if the MCV is high, it's called macrocytic anemia. Now we wonder why we want to do this. And this is very clearly done because it is associated with a mantra, a kind of a pattern. And in medicine, you all know we do what is called as pattern recognition. It helps us to recognize a pattern. For example, hypochromic microcytic anemia has a mantra, and that is iron deficiency, thalassemia minor, or TRE, sideroblastic anemia, anemia of chronic disease, or lead toxicity. So once you've got a hypomicro, suddenly our focus shifts to these 5 differentials as our main front runners, and we ask a history examination again, if not asked, based on these, and then do the test to satisfy this query. On the other hand, if it's macrocytic, how diametrically opposite you can see are the mantra now. It's megaloblastic, either B12 or folic acid deficiency, hypothyroidism, liver disease, underlying malignancy, hemolysis, or myelodysplastic syndrome. So it's a complete paradigm change in our thinking, investigation, and treatment. If it's normochromic normocytic, usually we have to remember 3 H's: hemolysis, hemorrhage, or hematinic therapy response. If it's none of these, then normochromic normocytic anemia to most hematologists would invite a bone marrow examination in that patient. But we have an advantage in hematology. We like seeing our slides. So seeing is believing for us, and we see our own slides under the microscope. So sometimes you can get a diagnosis clean from the peripheral smear, and this is the ace up our sleeve that we have as hematologists. We can look at the cells, the behavior, the pattern, the morphology, to see whether we can pick up any abnormality. And you'll be surprised. Sometimes this peripheral smear is diagnostic, which the CBC can never give you a diagnosis. It can only tell you numbers which you have to interpret. But smear can give you a diagnosis. That's the value of looking at peripheral smears. And if it doesn't give you a diagnosis, at least it gives you a direction for further investigations and therapy. I'm showing on the slide just now hypomicro cells. This is classically iron deficiency anemia. This is hypomicro cells, but they're not very small with nucleated red cells. This is a classical beta thalassemia major. These are 2 types of cells, some which are normochromic normocytic and some which are hypo with odd shapes and sizes. And this is a sideroblastic anemia. This is macro-ovalocytes which are seen on the smear. And this patient has a boiled tongue and has hyperpigmentation of the skin over the knuckles and fingers. This is classically vitamin B12 deficiency. You got in this cell polychromasia, that is blue looking cells with these dark cells which look like spherocytes. And this is a classical state of autoimmune hemolytic anemia. These here are cells where there's polychromasia, but you see these line-like cells. These are sickle cells, and one simple slide has made you a diagnosis of sickle cell anemia or sickle cell trait. If you start seeing such broken cells, these are fragmented red cells. They are poor for the patient's health, and they are usually associated with a very sinister cause called microangiopathic hemolytic anemia. And if you start seeing cells which are in ribbons or stuck to each other, this is rouleau formation usually seen in chronic infections, inflammations, tuberculosis, or malignancy. Last but not the least, sometimes you're stuck with a diagnosis and you see cells like these, which are called bite cells. It's as if it is bitten off, like the apple sign. They're bitten off This is typically seen in drug-induced hemolytic anemia. This patient had taken dapsone and forgot to tell it to us, and the anemia was part of dapsone. We stopped the dapsone and the hemoglobin improved. So sometimes just a good peripheral smear can give you a diagnosis. Now, while you looked at the hypomicro, macro, and normo in CBC, clinically, how do we as hematologists want to classify anemia? So production, destruction, and loss are the three compartments we look at. So production is usually associated with iron deficiency, B12 deficiency, folic acid, or certain drugs which can suppress the bone marrow. Invariably, if we don't get an answer here, we could end up doing a bone marrow examination. In destruction, the patient usually exhibits jaundice. There is a hepatosplenomegaly, urine is dark in color, and such people can either have an immune or non-immune. In the commonest in our country would be then G6PD, especially in certain communities, which can cause severe hemolysis. Others are like PNH and autoimmune hemolytic anemia. In losses, commonest is GI blood loss, especially with piles or hematemesis, or it can be in a female with menorrhagia. And usually the history of bleeding has to be elicited and we should be able to get it. I wish life was that simple. Sometimes there are combinations and we may not just have one compartment. And sometimes the loss of blood gives rise to decreased production because of iron deficiency or associated vitamin deficiencies. So sometimes it can be a mixed bag. So in terms of anemia, I think we carry the global burden of anemia in the world, especially with iron deficiency anemia. And you see the age range over here, irrespective of which age we have, almost 40 to 60% of our patients have got anemia as a cause, and iron deficiency being the most commonest cause of anemia. Now, oral iron is the mainstay of iron deficiency anemia treatment because for me, it is Sasta, Badhiya, Tikau, Mazboot, Sundar. There's no doubt about it. It's fantastic. And now we've got newer oral iron preparations available in the form of sucrosomal iron and chelates. So the drug delivery has improved so that we can fool the gastrointestinal system and get a better absorption of these oral irons. But at the end of the day, patients cannot tolerate in a large number. I think the current data is 60% of our patients on oral iron cannot tolerate oral iron therapy in patients who got iron deficiency anemia. Therefore, there have always been a need to search for an alternative source to take care of iron deficiencies other than oral therapy. And importantly, before we go to any alternative forms of oral iron therapy, it is extremely important that we diagnose iron deficiency well. So it's diagnosed by doing a ferritin. Ferritin is a very stable glycoprotein. It's not affected by recent iron intake. So ferritin levels, if it is less than 30, especially 15, it's highly diagnostic of iron deficiency anemia. However, if there is an ongoing inflammation in the body, then doing serum iron studies would be preferable because then ferritin is an acute phase reactant and it may be falsely elevated in patients with inflammation and hence may not accurately reflect the iron status of the patient. The gold standard, if you ask us, is bone marrow iron studies by Prussian blue staining, but it's an invasive process, so we will not be doing it. Two more new tests have been included in the market today, which we're not doing regularly unless we are stuck between anemia of chronic disease and a hidden iron deficiency anemia, which is called functional iron deficiency. There we do soluble transferrin receptors. If the soluble transferrin receptor level is high, there is iron deficiency. And we also do sometimes serum hepcidin level. If the hepcidin level is high, iron is not being absorbed. And it could be a good way of looking at whether we should not give oral and give IV instead. So what has changed? Treatment options have changed. We have switched more and more. I, for one, have switched more and more to IV iron therapy because as a treating physician, I want the hemoglobin up. And if it's not possible by oral, so be it by IV. And now we've got more options for parenteral. I've almost stopped using intramuscular for more than 10 years. It's IV that I use or oral as my choice. And these IV preparations, which are newer now, are safer, less toxic, and more effective. So the thinking that oral iron will be the first line of treatment and then IV should be given for those who do not tolerate it is slowly changing, especially in pregnancy and especially in cardiology. Those patients of cardiac failure who got iron deficiency, Dr. Satya will tell you that IV iron therapy makes a lot of difference to them. And I've seen them, their quality of life improve after taking IV iron. So there is a paradigm change in the thinking of when we should place IV ion therapy, and it is becoming more and more common upfront. With IV ion, the newer ones, we have got lesser clinic visits as opposed to iron sucrose, which could be given only up to 200 milligram, had to come very often, improve patient compliance, and importantly, reduce need of blood transfusions, which for me is like putting petrol into a car. Is just temporary. You have to make your own petrol, and we thank God that IV is available for us in terms of improving hemoglobin. And yes, it is expensive, but at the end of the day, if you look at the number of visits and all the ancillary issues that take place with anemia, I think still the benefit of IV iron exists. Now, what is the properties of this parenteral iron? We had iron dextran, we had iron sucrose, and we had iron carboxymaltose. We also now have isomaltoside, we have ferrimoxytol. So we are getting newer and newer preparations, which is very good. See the advantage of ferric carboxymaltose, which is available to us through many companies. If within a matter of 15 minutes, we are able to give up to 1 gram, which is not possible with the others without inciting a reaction. That's a big advantage we have with the IVN therapy. Its indications have spread. We are now using it in pregnancy in second trimester. We are using it in third trimester. We're using it for pure param when the patient is going to be discharged to improve the hemoglobin status. We are using it post-operative. We are using it in those who are intolerant to oral iron. We are using for those who got inflammation and cannot tolerate the oral iron. So it's just phenomenal, the number of indications that are there. There's a dose calculation by the Ganzoni's formula, but simply put, if you got a patient which is around 50, 60, 70 kilograms and the hemoglobin is more than 10, 1 gram would be the dose that could be given. And if the weight is much more, then you can give up to 1.5. Rarely I've had to use 1.5 at one time. In fact, I've never used it. If the hemoglobin is less than 10 and the weight is on the lesser side, you can go up to 1,500 milligram. Again, I've never given on one dose. I've always given it 1 gram first and then 500 the second time. Now, the maximum, people ask me, how is it to be given? This is a standard formula. It will be there in all the product inserts of companies which will give you ferric carboxymaltose intravenously. So if you're using somewhere between 200 to 500 milligrams, you can put it in 100 ml normal saline and give it over 6 minutes. If it's anything above 500 to 1000, between 500 to 1000, then you can dilute it up to 250 and give it over 15 minutes. Now, Dr. Sathe may not allow me to give 250 ml to his patients of cardiology in a matter of 15 minutes. So many times we've had to split the doses so that it can be given much easily, which could invite 2 visits to the hospital rather than a single visit to the hospital. It is not without side effects. There are adverse events to every drug, and so also with the IV preparation of ferric carboxymaltose. These are mentioned here, but I must tell you, they're very few and far in between and very easily treated. The most common is a little bit of nausea, dyspepsia, or flatulence. Sometimes there is itching, sometimes a little bit of darkening of the skin, arthralgia, and sometimes they've got cramps in the leg, and that's because of the hypophosphatemia which takes place. There is an iron isomaltoside also available. Excellent. It has also been studied very well, and it can also be given in a dose of 20 milligram per kilogram. So you can give it 1000 milligrams also to a 50 kilogram person without a problem. And it has also been studied in various situations. Other than iron deficiency, I must introduce you to hemoglobinopathies, which are very common in our country. So sometimes these two come together, and you might have a thalassemia who has got iron deficiency, and therefore sometimes we have to dig out this thalassemia, especially when they are pregnant, so that we don't miss out on a chance that the child might become a thalassemia minor or major. So here I would strongly tell you, look at the MCH, which is why I want a printed automated CBC report. Have a look at the MCH. If the MCH is more than 27, then in that case, look at the ferritin and HB electrophoresis. If ferritin is normal, there is no iron deficiency. If the hemoglobin electrophoresis by HPLC is normal, it can still be an alpha thalassemia, but you have ruled out beta thalassemia. The moment the MCH starts dropping along with the MCV, and the MCV also starts dropping, especially below 76, then there is a possibility that things can coexist. So look at the ferritin. If the MCH is low, MCV is low, ferritin is normal, this rules out iron deficiency. But if the A2 is high, this is a carrier for beta thalassemia. Or you pick up some other pattern like hemoglobin S or hemoglobin D or hemoglobin E, then that is a carrier for a hemoglobinopathy in this patient. But that you can pick up by doing an HB electrophoresis. If the MCH is low, MCV is also low, and the ferritin is low, this is typically iron deficiency, but thalassemia may coexist. So don't do a thalassemia at this point of time. Wait for the iron to get corrected and then do the thalassemia status. And you might pick up a coexisting thalassemia in such patients. If a patient is a pregnancy patient, you can't wait. Do the husband's thalassemia status and see whether he's minor, because that will tell you whether you should be worried about the female and her pregnancy or not. Commonly asked question to me is, can a thalassemia minor patient be given iron therapy because they are somehow told don't take? My answer is give. If there is iron deficiency, you got proof, you must give iron therapy to thalassemia minor patients so that they can improve their hemoglobin. So the algorithm in such situations would be, look at the CBC, look at the MCV and MCH. So if it's a low MCV, low MCH, especially if the MCH is below 76 and MCH is below 27, look at the RBC count and the MCHC. So in this situation, if the RBC count is normal and the MCHC is normal, you know that this is more likely going to be thalassemia. Do a hemoglobin electrophoresis. If the A2 is raised, this is going to be a beta thalassemia trait. If you're still suspecting and the A2 has come normal, you can still have something called a silent beta thal. So you can do a DNA PCR and look at the 8 common mutations that we have in our country. On the other hand, if you do an HB electrophoresis and A2 comes normal, it could still be a silent beta thal, but then it could also be an alpha thalassemia. So you can do a DNA PCR for alpha thalassemia. On the other hand, if the MCV, MCH is low and the RBC and MCHC count is also low, that means everything is low, most likely this is going to be iron deficiency. You can prove the same by serum ferritin or iron studies. And then don't forget to look for the etiology. Don't just treat it and go ahead. Sometimes, despite your best efforts, you will have a situation where the patient doesn't have any of these common diseases and has something which is called as refractory anemia or unresponsive or truly undiagnosed anemia. And they're not responding to standard line of treatment, or we don't have a common cause. So then we look at myelodysplasia, sideroblastic anemia, anemia of systemic disease, anemia of cancers, and the thalassemias in their silent forms. Usually, such people end up needing transfusions, bone marrow examination, and we do specialized tests in them, including next generation sequencing, to be able to tell, is there anything sinister or mutational that could be the reason for this patient? So what makes you tilt to do a bone marrow examination in anemia? So all of us hematologists who are sitting at the microscope, not able to get an answer, we are squirming in our seats with the investigation and the peripheral smear, we know we have to tilt our balance towards doing a bone marrow examination. So if you've got a good history and examination and a relevant test has proved that we cannot get an answer, then we should go for a marrow. And otherwise, we can also prevent unnecessary marrow examinations. Once the decision is taken to do a marrow, we should do it completely properly, a complete analysis to be able to get a diagnosis. Now, in the next 7 or 8 minutes, I'm going to show you some case vignettes and red herrings in anemia. And we always thought anemia is no big deal, but sometimes you'll be surprised at what is there. So don't believe everything or anything at face value. Be a little bit investigative. And sometimes I think that in medicine, all of us are like Sherlock Holmes. We're searching for that occult to see that we've not missed something. And in today's world, especially, we can't afford to miss anything which is underlying. So this is your 54-year-old gentleman who came for a routine health checkup. He's an active badminton player. He has no complaints. He did a routine health checkup as part of his company requirement. And his hemoglobin came as 7, WBC 3,300, and platelets were 28,000. And he was sent across immediately for admission and bone marrow examination. In this situation, going through the history and physical finding, it was obvious that this did not fit him. It looked like this patient and this report are of 2 different individuals. In such a situation, a CBC was repeated and the sample came as normal. This patient's values are all normal. In the sample which was given earlier, there was a clot in the sample, and that's why the reports came wrong, because the clot utilized the cells and therefore we got wrong results. So a value of a CBC automated report is only as good as what has been fed into that machine. So if you feed it a wrong sample or an inadequate sample, it will give you a wrong and inadequate report. So just don't believe a report. You should have CPC, a clinical path correlation. This 19-year-old girl had symptomatic anemia. Hemoglobin was 9. Look at her indices, they're all low, but the MCHC is normal. Once MCHC is normal and the RBC count is normal, you know that the chance of this being iron deficiency is less likely. She's received iron, she's received beta because that's what everyone takes. We did a hemoglobin electrophoresis and it showed that her hemoglobin A2 was not high. It was in fact low, below 2, 1.8. Now remember in practice that once the A2 goes lower than 2, the chance of alpha thalassemia is much higher. So I did her DNA PCR and she turned out to be alpha thalassemia. So sometimes we just end up giving patients lots of iron therapy and B12 and what have you from one company to another, and actually the patient has something else. This is the same 19-year-old, but a male this time, and he's also symptomatic, taken lots of therapies, and for the last 3 months his hemoglobin is low. His hemoglobin is 7. Look at his MCV, it's not low, it is on the slightly higher side, 99. Look at the RBC count, it is low. From this itself, it should be known that it's a hypoproductive anemia. The red cells are being low, our hemoglobin is low, that means he's producing less hemoglobin. The usual stuff was done, everything came normal. So we had no choice. I told you most hematologists would end up doing a bone marrow examination here. And what we picked up was pure red cell aplasia. Only the red cells inside the bone marrow were affected. Usually it's called Diamond-Blackfan anemia in children. This can be associated with thymomas. Usually they respond very well to immunosuppressive therapies. Immunoglobulin 1 and steroids is the other. And they do very well. If not, they'll have to do a bone marrow transplantation. This is a 69-year-old male, a retired IT professional. He had chest pain and was planned for an urgent angio. He got it done. It was stented. He was shifted to ICU post the stenting for observation. What they noticed in the evening was a rapidly dropping hemoglobin. There was no blood loss during the procedure other than the standard amount that was there, but it had dropped enough for them to give blood. So let's look at the data. Before the angio, it was 11.9 hemoglobin. Later on, it dropped to 8.3. And then about a day and a half later, it had dropped to 6.8 and he was given 3 units of transfusion. There was no hemolysis. The urine was clear. He was conscious and oriented. His reticulocyte count is normal. And in such a situation, his smear also was fine. What the smear showed, however, was polychromasia. And there's nothing else. He passed stools. There was no blood loss in it. Essentially started complaining of abdominal pain, and what he had was a large retoperitoneal hematoma, which was probably a counterpuncture which had taken place at that time. So he didn't come with anemia, but sometimes you get anemia in the hospital and you have to look at it from a good history and clinical examination point of view. This is a 72-year-old retired professor. He came with fatigue, loss of appetite, and a dark urine. He looked jaundiced. He was admitted for transfusion. But when they sent a sample for cross-match, they could not get blood available for him. Hemoglobin was 6.9. White cell count was 65,400. Platelets 132, an absolute lymphocyte count of 47,000. His smear showed all lymphocytes, and it was apparent that he most likely has chronic lymphatic leukemia. Now, chronic lymphatic leukemia with a white cell count of 65,000, Vijay Ramanan and me will not treat. We'll say, just hold on. But with a drop in hemoglobin, we are worried as to what it is. And therefore, since there was no bulky disease, it appeared that this CLL was not, the hemoglobin was dropping as part of the CLL effect on the red cells, and that's called autoimmune hemolytic anemia. This patient responded very well to steroid therapy. So in CLL, we found the etiology of anemia to be antibody guided, and we treated that part and we left the CLL alone. Automatically, of course, with steroid, CLL do get treated, but the patient's hemoglobin came up very well. This is a 32-year-old male. He is asymptomatic other than fatigue, but he has recurrent iron deficiency anemia. He's gone to 3 other doctors. He responds well to oral iron therapy, only for it to drop again. And he's eating well, he's 32. So in this situation, what comes in front of us is continue replacement therapy, just leave him alone and observe, do an endoscopy, or we start looking for malabsorption because he's 32, probably not absorbing. So there is Crohn's disease, ulcerative colitis, celiac disease. What happened in this case? We did an endoscopic evaluation in him because we also took a history, and there was a strong family history of malignancy in this patient. And he turned out to have a CA colon, which got resected. And since we had picked it up early, he didn't need chemotherapy. This is a 63-year-old female who is a housewife. She has got pains, especially knee pains and bone pains, and a hepatosplenomegaly. This is her CBC. You'll see her white cells are just borderline, platelets are just borderline, but the hemoglobin drop is much more than the others. So predominantly symptomatic for low hemoglobin. Her liver function test was normal, so it's less likely that it is the underlying cirrhotic liver. And what I saw on the smear, which sparked off a thought process, were these teardrop cells. Can you see these beautiful teardrop cells? They augur for something called poorly for something called as fibrosis, myelofibrosis. And this patient's marrow showed all fibers inside the bone marrow, which is clear on the reticulin staining that this was primary myelofibrosis, which causes hepatosplenomegaly, anemia, fatigue, and a loss of quality of life. This is a male who had very odd looking cells on the smear. He presented as anemia, and we ended up doing a bone marrow examination. He was transfusion dependent. He turned out to be a myelodysplastic syndrome, which is another cause of refractory anemia. We treated him with azacitidine. Even now he's transfusion dependent, but not so frequently. In fact, his requirements have come down significantly. We did his NGS test, picked up lots of changes in mutations to prove the diagnosis that it was a primary myelodysplastic syndrome. This is the patient, my last case, where we had a patient who had 10 kilogram loss over 6 months. No obvious loss from anywhere. Hemoglobin dropped from 11.8 to 6.5. Is post transfusion. Hemoglobin was 10. Scopy was done, upper and lower. Nothing came up there. Subsequently, after 9 days, the hemoglobin again started coming down. Again, a stool local blood was repeated, and it came positive, and that's why colonoscopy was repeated. And they picked up angiodysplasia. The reason I'm putting this is because sometimes we feel that once an endoscopy is done, you should not be repeating it. Don't forget, endoscopy depends a large amount on what is the available pathophysiology at that time. And sometimes there's something called as Cameron's ulcers, which are hidden ulcers near the at the end of the esophagus, which may not be easily negotiable and seen. And they can be missed by someone who's not looking for it. Even angiodysplasias may not be active at one point of time, but when they're actively bleeding, you actually pick it up very well. This patient did very well with APC, argon laser, and the patient stopped bleeding. So I'd like to conclude by saying that every specialty faces anemia, and you're going to listen to two more specialties, one of cardiology, the other nephrology. Pathologists and hematologists should diagnose anemia by a stepwise approach with an automated CBC and a peripheral smear. Anemia is an event. A relevant investigation should be done to find out the underlying etiology. So untie the pathophysiology, use CPC, and keep revisiting the diagnosis till everything fits the bill. Sometimes we may need to do a marrow examination. And then if we find the answer, treatment should be carried out as per the defect or correct the underlying cause and avoid transfusion as much as possible. It's a very rare product to get. People don't generally donate. And that's why it should be given to the right patients and not just to bring up a number. And we should assess response to our treatment often to see that we were right in our diagnosis. And if there's inadequate response, we must revisit our diagnosis. We are not gods. We can revisit and find out whether a mistake was made and whether there's an alternative or a hidden diagnosis that was missed. So many times, I get calls from colleagues. I make calls to my colleagues. We speak to each other. So communication, discussion, and opinions is very important. And sometimes someone just throws the light on you and you say, oh, eureka, the answer is obtained, and we make a diagnosis. So don't hesitate to talk to each other and come to a diagnosis. But it's very important that whatever happens, whoever diagnoses, the patient should improve in terms of hemoglobin, and we should do well. So I thank you very much for your attention, and I hand it back to Dr. Sathe and his team. You're on mute, Vijay. You're on mute.
This is on mute. Thanks. So, basic mistake. So, thanks, Dr. Abhivavi, for a very lucid and simple talk and introducing us to the topic, to the the concept of cause and effect and quantity and quality on CBC and ace up the sleeve by looking at the smear. I don't know how many questions are there, but I have few questions. You've answered many of the questions that I've written. Do you deworm every iron deficiency that you find? Is one of the questions. Do you deworm? And what is the endpoint of ferritin value in treating an iron deficiency anemia patient, or even a thal you are supplementing iron? What would be your target ferritin value?
Yeah, that's a great question. So all patients who got iron deficiency anemia will receive deworming.
I
There's no
think you
doubt
are on
about it.
mute.
Oh, I'm not on mute. You can't hear me? I'm not on mute. Can you hear me?
Yeah, we can hear you. Yeah.
Okay, so all patients of iron deficiency would receive deworming. There's no doubt about that. How much is going to help, because everyone doesn't have iron deficiency, but a worm infestation, sorry, but it's worth it. We must give it, especially the kind of food that we eat. Our gut is exposed to a lot of food from different sources, if I can put it that way. So it's good to in terms of ferritin, I think the targets of ferritin in pregnancy are very well established. So getting the ferritin up above 50 is an important target. For anemia of chronic disease, renal dysfunctions, end-stage renal disease, the ferritin target is 100. In other cases, there is no specific target, but if you can bring up the hemoglobin adequately and give iron for a period of 3 to 6 months, that should take care of the ferritin. If the hemoglobin doesn't come up, then we counter check with the ferritin to see whether the ferritin has gone up, especially for those taking oral iron. If you're taking IV iron, the ferritin levels will be very high. There is no advantage of doing ferritin.
Do you routinely use soluble transferrin receptor to the ferritin index, or the CRP for evaluation as such in your patients if you suspect inflammation?
So soluble transferrin receptors, I have used it only in those situations where I've got a patient with anemia. The standard tests of iron deficiency, such as ferritin and iron studies, have not contributed to a diagnosis of iron deficiency, but I'm clinically suspecting. So in that situation, I do a soluble transferrin receptor. If the level is high, then I know that I'm dealing with an iron deficiency, and I still give them iron therapy. If they've been on oral, I switch over to IV iron therapy. As far as CRP is concerned, it is a good tool to look for infection or inflammation, but I don't use it to guide my treatment or adequacy of treatment.
In a patient therapy, Dr. Sathi will be addressing that. After the IV iron, do you believe in following it up with oral iron?
That's a great question. So the fact that I gave IV iron to my patient is because the patient was not tolerating oral iron. So my answer is no. If I'm going to give IV iron, I will not give oral iron. I might give a gap of around 6 weeks to 3 months, and then consider giving oral iron to the patient if the ferritin is still on the lesser side or is not reached the levels that I expect, or if the patient doesn't now want to take IV iron because it is on the expensive side. I'll change the oral formulation and use.
Do you regularly do Scopies for your elderly iron deficiency anemias, or use RBC TAG scan or something like that?
Great questions. So as per the AGA, American Gastroenterology Association, in adults, if there is an iron deficiency anemia, it is mandatory to do a bidirectional endoscopy, that is upper and lower GI scopy. So yes, I recommend all my patients to undergo it, and you'll be surprised what all sometimes you've picked up. Vijay, you and me have picked up so many things in these patients. But you have to sometimes use your discretion. Sometimes it's very clear that the female in front of you has menorrhagia, and therefore the cause of iron deficiency is very obvious. So then you have to use your personal discretion and say, no, In this situation, there is iron deficiency. The etiology is more likely to be because of blood loss, or there is some piles bleeding, or there is a known case of cirrhotic liver with hematemesis. So, or there is you diagnose the patient already to have an angiodysplasia and they are bleeding recurrently. So unless they're bleeding actively and you want to stop the bleed, otherwise you would not do it very often. So it's your personal discretion, but more often than not on paper, I will write that you have to do endoscopy. Yes. 67% of the times, the answer of iron deficiency anemia is in the gut. Published data.
Do you see HST or Osler-Weber-Rendu in your practice? And do you do the mutation analysis for VEGF?
I've not done the mutation analysis. Thankfully, we don't see this very often. But yes, I've got 3 families, and I've tried giving them thalidomide. I've tried giving them lenalidomide. I've tried giving them small doses of steroids. I've tried to do lasers at the sites of the bigger bleeds. And in the last patient, I've given bevacizumab.
Do you see iron-resistant iron deficiency anemia?
Yes.
Do you do TMPRSS6?
You're supposed to do it. I've not seen it so often. I don't know what's your experience. Probably you are doing it more than I'm doing it. But our responses have been pretty good to oral or IV iron therapy. So I've not done this test very often. Tempest test I've not done very often.
My patients don't do it, even if I recommended them. Do you do the oral iron absorption test? There's an old entity that was there. You give a 300 milligram of ferrous sulfate and then check the iron going up. Have you ever done that? Or it's an
no way.
No way.
No way. I'll not give anyone ferrous sulfate.
Because
Sorry,
it's a 1980 study. So.
Yeah, I've stopped using ferrous sulfate after my MBBS.
Dr. Sati has a question. In a normal person with iron deficiency anemia, no cardiac failure, nothing, would you use the ferric carboxypolymaltose or would you use older preparations of iron?
So you're looking at a person who's got a cardiac failure.
No cardiac failure.
No cardiac failure. Iron deficiency anemia, proven. And the question is whether we can use ferric carboxymaltose. I've lost your voice.
It's the echo. This is a normal person without failure, cardiac failure. Would you recommend ferric carboxypolymaltose, or would you go with the older iron preparation?
No. So older iron preparations like iron sucrose will need multiple admissions because you can't exceed 200 to 300 milligram at one time, and your dose is 1 gram. So it means 5 admissions. So yes. No, I'm sticking to the newer ones.
Intravenous. What would be your choice?
Intravenous is the one if they can't tolerate oral. So my first choice is always oral. If they can't tolerate oral, I go to IV.
Thank you, sir. Yeah, this was a ASH paper long time, 3 years back, I think, where alternate day oral iron therapy to reduce the hepcidin spikes. So do you believe in it, or how do you implement into your practice?
I not only believe it, I practice it. So whoever has asked that question is up to date, because just for the audience, once you take a tablet of oral iron, then there is a consequent release of hepcidin, which inhibits ferroportin from absorbing iron. So the next day when you take a tablet of iron, what happens is that you get iron toxicity in the gut and inadequate absorption at the mucosal level. So the toxicity is more, the benefit or absorption is less. So if you use it alternate day, then the hepcidin level comes down. So then the day after when you take the tablet, absorption is better. So yes, it's been published, and I use it for those who are not tolerating daily iron. I go to alternate iron, beautiful responses. And I just go once a day and I'll put my neck out further. I give it after food. I don't give it before food.
Do you use heme polypeptide? Do you think it's better than the present preparation? Do you use iron with lactoferrin? These are all fancy things, oral iron, which have come with fancy additions.
Yeah. I mean, for those who cannot tolerate oral iron in its conventional form and who do not want to take IV, because we have to tell them about side effects, very rare anaphylactic reactions. I ask them to read about the drug. So then, yeah, you have to use something which is different. And these drugs, which are the newer preparations, they are like Trojan horses. They can carry the iron right up to the gut and absorb it much better. So yes, I have used them, and they have been beneficial.
So thank you, sir. These are the questions that we have. So we'll go ahead with the next lecture.
Yeah, I just want to say thanks to Dr. Sathe
Yeah, he's
and to the team of MCure for the opportunity to interact. And it's been a real pleasure. And Vijay, thank you very much for being there.
thank you, sir. It was a pleasure.
Thank you, Dr. Bhave and Dr. Ramanan. I think that was an excellent talk and very good discussion. Thanks, Dr. Ramanan, and both of you for a very interesting discussion. I think we'll move on to the next talk. I'll invite Professor Dr. Anil Kandare on the dais as the chairman. Dr. Kandare doesn't require any introduction. He's a very difficult man to get as a chairman, but I must tell you that he's been my teacher since my MD days. And when I was doing my MD medicine, in fact, I used to sit in his clinic for an hour or so just to get him to teach us and get his clinics. So he is an excellent teacher, a great academician from KEM Bombay. And it's a pleasure to have Dr. Kandare with us.
Sandeep, sir, presentation.
Good morning, everybody. Dr. Sathe is a very well-known leading interventional cardiologist. I don't have to say anything about it. Only one thing I would like to mention is he was the first cardiologist in Pune. I'm talking about in mid-90s. At that time, the stents were introduced for the first time, and cardiologists used to require a permission to implant the stents, and he was the first cardiologist to get that permission in Pune. Apart from an intervention, he also has a lot of interest in the other aspects of cardiology, especially the preventive cardiology, and he has been running many courses in the same aspect. I invite Dr. Sathe to give his talk on 4 pillars of treatment of congestive heart failure.
Thank
Sathe,
you,
please.
Dr. Kandare. Dear friends, this is a talk on heart failure where we talk about 4 pillars and beyond. As you all know that the treatment of heart failure has been revolutionized since these new drugs have come. And if you see heart failure as such, it was initially the concept was congestive heart failure, that means ADHF, acute congestive state, and chronic heart failure. With chronic heart failure, we were concentrating on hospitalization and mortality. So these were the 2 subsets where the whole concentration was, and different drugs came for these 2 concepts, for acute phase and for chronic heart failure. And with these 4 pillars, in this lecture, I'm going to just give you a gist of 4 because it's a long talk, but I'll just give you the gist. what are the four pillars? All these drugs came basically for the second half. That means chronic heart failure to decrease hospitalization and mortality. Then we'll see why we have to go think of going beyond four pillars. And then the concept of the CDMMT, that is modifying disease modifying medical treatment, how the concepts are changing when you are treating patients with heart failure. Now, why are we supposed to look beyond four pillars? This is because if you see in our day-to-day practice, still we have significant number of patients who have a residual risk of death after giving all the optimized medications. There are still hospitalizations with heart failure. Mortality has come down, but not perfect. And especially patients with renal dysfunction and very low EF are still having problems controlling their heart failure admissions. That is why we have to look beyond four pillars. When we look at four pillars, we all know beta blockers, ARNI, SGL2, and MRAs, that means receptor and mineralocorticoid receptor antagonists. Now, I'm going to give you the whole data because it's too long. I'll give you the gist, the practical points about these four pillars first, and then we'll go on to the what is beyond four pillars. Beta blockers, a few things you must know. First interesting thing you must know that, of course, it came because it inhibits catechol and cardiotoxicity. We all know that, and all the features of toxicity which are having prevented beta blockers. We'll not go into those mechanisms. But the curves diverge at 9 to 12 months. Remember this. So when we start beta blockers, decreased hospitalization or mortality starts, the curve starts diverging somewhere between 9 months to 12 months. This is important. And the other two aspects we will see is withdrawal during it. Suppose somebody is admitted in the CCU with acute decompensation, what do you do with beta blockers? And then the choice of beta blockers, just one slide on that. Now, this is an important thing. Suppose we have an admission of a known patient with heart failure with ADHF. Patient is admitted with Krebs, orthopnea, and he's admitted with LVF. What do you do with beta blockers? Patient is already on beta blockers. Now, should we withdraw? Should we decrease the dose? And when should we reintroduce? This is important. Now, except, remember this is a very good paper on all these three aspects. Number one, if your patient is on inotropes in the ICU for hypotension, in congestive heart failure, is clinically Stevenson's classification cold and wet, you should withdraw beta blockers at that particular time. No question about it. It's very, very clear. Suppose this is not there, patient is admitted with this diuretics, patient has been settled, not cold and wet, is reasonably okay clinically, then you don't. Then there's a very good paper which says if you withdraw beta blockers, then in fact the mortality is higher. Okay, so don't withdraw beta blockers. Do you reduce the dose to half? Again, there is a paper which says that either you withdraw or you don't withdraw. Reducing it to half doesn't help. Okay, so if your patient is on inotropes, cold and wet, Stevenson's classification, then you withdraw. Otherwise, don't withdraw. Okay. When do you reintroduce? If you have withdrawn because of the clinical hemodynamics in the CCU, then you start reintroducing within a short time, within a week's time, or in your first OPD follow-up with a smaller dose. Because remember, your mortality curves again start diverging slowly. So it is not that you give a drug today, but that is why you should start it early. But that is why clinical discretion in ADHF is important. And this is the data whether to withdraw or not to withdraw beta blockers during the admission of heart failure. Which beta blocker to use? I'm not going to read this, but in general, bisoprolol, metoprolol, and carvedilol are perhaps the most commonly used beta blockers. Of course, there are subset specific indications given, but overall, with these three beta blockers, is there head-to-head comparison? No, there's no head-to-head comparison. Use your clinical discretion and the clinical subset to decide the dose and the subset in which you are going to give beta blockers. What is the pulse rate at which you stop? In general, what you have to target is that the pulse rate when the patient is beta blocker should be at rest less than 85. 65 to 85 is okay. That's number one. And number two, you have to see what happens to the pulse rate when the patient does mild to moderate exercise. That means normal exercise capacity the patient has. It does happen sometimes when you over beta blockade. The patients may complain of fatigue during exertion because the rate doesn't increase aptly to the exercise what the rate is required during that exercise. So these are the two factors you have to see about heart rate and beta blockers. The next is ARNI. First important point, the curves of hospitalization mortality diverge as early as 4 weeks. This is important as compared to beta blockers. We look at what are the predictors of good response. And the last point, ADHF, acute decompensated heart failure, AMI, acute AMI with LV dysfunction and preserved EF, in general, the mortality data has come negative, but the trends of NT-proBNP are positive. So, do you recommend in all patients of ADHF, AMI and preserved? No. There are a subset of patients where we think about this. Now, practical point is AMI with acute systolic dysfunction. We are not going to start in the pre-discharge. But when do you consider this as chronic heart failure? Now, there's a slight debate on this, that whether it should be 4 weeks or 3 months. So, if a patient of AMI, whether you have thrombolized, whether you have done an angioplasty, if the patient has complained, it's a rescue angioplasty, if there is LV systolic dysfunction, then at 4 weeks to 3 months, if after that time is given for remodeling, if the patient still has significant LV systolic dysfunction, then you should consider this as chronic heart failure and start ARNI on these patients. Now, what are the predictors of recovery of LV function? Non-ischemic, dilated cardiomyopathy, non-ischemic, smaller baseline left ventricular, that means your LVEDs are not very high, higher initial BP, your BP, systolic BP is 120 and above, and larger initial dose of ARNI.
नाही ते तेवढंच दिसेल. आता इथून जो आपण हे करतोय
Okay. So, if you giving ARNI, then dilated cardiomyopathy, smaller baseline LVADs, higher initial blood pressure, and higher dose of initial ARNI. That means suppose you start with 50 BD or 100 BD, then the response to ARNI is far better as compared to when you start with lower doses. Now, CKD and ARNI works in almost all subsets of CKD, except when when the eGFR is less than 30 and less than 25. Of course, you should not give ARNI. Now, here is an important point. What happens to create an eGFR when you start ARNI? What do you do? Overall, the previously concept was that suppose you give ARNI to a patient with heart failure. If there is a rise of serum creatinine suddenly within 2 weeks for more than 25%, then you should consider stopping. That was the previous concept for ACE, ARB and everything. But now, of course, it is clearly mentioned in this slide that less than 50% you should continue. So less than 50% of rise in serum creatinine in the first 4 weeks, you wait. Don't stop or reduce ARNI. If it is between 50 and 100, you reduce the dose of ARNI. And if it is more than 100%, that means suppose somebody's creat is 1.8 and it goes to 3.6, more than 100% twice, then of course you stop ARNI. So because you will realize that initially there is always a small rise in the serum creatinine or a decrease in eGFR, but over a period of time, especially 6 months to 1 year, the hemodynamic, as the hemodynamics improve, the renal function improves. So this is, you should not have that knee-jerk reaction that if the creat rises, you should decrease or stop ARNI. As far as mode of death, just a practical point, besides hospitalization and mortality, sudden death, the incidence of sudden death has decreased with ARNI, and that is why if you see remodeling, that is why in fact ICD, the incidence of implanting of ICD, is a paper which says that ICD implants have decreased. Patients have been taken off transplant lists with the advent of army. So a lot of interesting data is coming with this, and more of death. The next is SGL2. Again, remember the mortality and hospitalization curves diverge at 4 weeks, as early as 4 weeks. So it's important. Robust data, either it's EMPA or DAPA, it's robust data. Ease of administration, no titration required. Limitation, of course, is severe CKD. And is there a comparison of EMPA versus DAPA, which you should use? Really, if you see head-to-head comparison, both are almost equal for reduction of mortality. But overall, if you see only CV deaths or all-cause deaths, perhaps DAPA has an edge. But overall, there is no head-to-head comparison, so we would not really. There is one interesting paper which says that the incidence of atrial flutter and fibrillation. Remember this. Over a period of time, if you give early DAPA to these patients, then the incidence of atrial fibrillation decreases. So I think this is an important paper on arrhythmias and SGLT2 inhibitors. MRAs, again, curves diverge at 12 weeks. Okay, so remember, 4 weeks, 12 weeks, and beta blockers, 8 to 9 months. This is important. We had emphasis HF, FSS, all of course decreased, improved LV remodeling, hospitalization, mortality. The important limitation of MRA is CKD patients and potassium. Okay, so remember this. So suppose somebody is borderline with these four pillars. If suppose somebody is borderline potassium is more than 5 or 5.5, touching 5.5. The first drug I would reduce is eplerenone rather than arni, and then think of the other drugs, because then people ask which would you omit. But the first thing I would omit out of these 4 pillars is, because if you see the data comparison between arni and eplerenone, perhaps arni has an edge if you see all the other parameters of heart failure. So these are the 4 pillars, just the gist. So now, why are we going to consider, before going to that, before and beyond? So this I'm just mentioning because this is what we were using before these 4 pillars. Digoxin, L-carnitine, coenzyme Q, nitrates, hydrolyzing. Should we use? Should we not use? Digoxin, remember, the DISH trial clearly showed. Now remember, if you see overall, if you see the usage and the deletion of drugs being used in the past, there are only 2 important factors which decide that. Number 1 is mortality benefits, and number 2, going off patent. If you find that a drug is going off patent and it has no mortality benefit, it will go out of use. They will not even come to you. That is what happened with DISH. DISH has 2 important things. Remember, no mortality benefit, but yes, you should still use in resistant cases because it does decrease hospitalization. So no question. The only problem with DISH is the narrow therapeutic range, and that is the problem with DISH. The toxicity comes very early, especially in a frail patient who is with congestive heart failure. That's why you have to be careful. But in a resistant case, if the patient has repeated hospitalizations, you should use digoxin today, because hospitalization benefit is certainly there for digoxin, though not mortality benefit. L-carnitine used to use blanket for so many years, not required now with these 4 pillars. But patients with adriamycin cardiotoxicity, there are 2 papers, 2 subsets. Number 1 is cancer-related cardiomyopathies. Number 1, especially adriamycin cardiomyopathy, and second is CKD-induced LV dysfunction. These are the 2 important parameters where I would still use L-carnitine, number 1. And again, resistant cases, suppose patients are coming with repeated hospitalizations, I would use as an empirical drug. Coenzyme Q, again, the same thing. Today, I would use for resistant cases as empirical drugs, not as the first line choice. And nitrates and hydrolyzing in hemodynamic states where patients are not improving. So if their pressures are okay, and to improve the hemodynamics, I would use. But again, remember, these are the 4 drugs which we used to use routinely. I would use it after I use my 4 pillars. Then why are we looking at, now why should I look beyond 4 pillars? And this is the reason. So what are the points beyond 4 pillars? See, this is what has happened. Still we have hospitalization. Still we have resistant cases. Still we find NT-proBNP is high in our patients with heart failure. And still we find that the mortality has not come down significantly in the significant number of the subset of patients. And that is why, what do I look at beyond 4 pillars? Simple. First is anemia correction. Second is Vasiugat. And third is amla captive macabre. Now, just a word about these 3. The first, the simplest one is anemia correction. In fact, there are papers now, there are people who are giving lectures saying that 5th pillar is anemia correction. And there are a lot of papers. I'm not going to details, FAIR-HF, CONFIRM-HF, AFFIRM-HF, INCRT. So what are the mechanisms? Again, let us not go into the mechanism of how anemia worsens heart failure. It's very clear that if a patient's hemoglobin is low, it worsens heart failure, or at least the hospitalizations may increase and the symptomatic improvement which the patient has will decrease despite giving all the 4 pillars. And that is where anemia has to be corrected. What is the recommendation? See here. For once the diagnostic workup in a de novo heart failure is a must in all patients. All patients it's recommended. All patients, no question about it. So hemoglobin, ferritin, and TSAT. So this is important, and then you may repeat 6 months to 1 year depending upon the response to hemoglobin and ferritin. So that is the recommendation in all patients with heart failure. Now, what do you look at? In fact, if you see the ACC guidelines, hemoglobin, of course, we look at. If hemoglobin is low, there is no question. But if it's not, what you look at is ferritin and TSAT. If the ferritin is less than 100, you have to give carboxymaltose to patients. If it is between 100, if it's 100 and 300, then look at TSAT. If TSAT is less than 20, then you give carboxymaltose. So look at hemoglobins, look at ferritin, and look at TSAT. So once you must do in all patients. Remember, nowadays, of course, we use carboxymaltose because except for the cost, which is exorbitant for a patient, in fact, it's a fantastic drug. I have used in hundreds of patients, and you must convince the patient that you don't have to like. So why are you thinking of using carboxymaltose or IV preparations rather than oral iron? And there's a scientific data on that. Absorption in heart failure patients is low. Why? Because there is gut edema. In fact, previously, remember, there was a therapy for heart failure for recurrent admissions. Used to give IV dobutamine and IV furosemide, and empirically, we used to admit the patients and give them every 6 months. The main reason was gut edema. You used to reduce the gut edema so that the absorption of drugs was better. So that was one of the principles why I used to give this therapy. So gut edema doesn't allow. Intolerance to oral iron, of course. And of course, what was mentioned is hepcidin block. Because of hepcidin block, the oral preparations, the absorption is very poor. So all the efficacy of iron is less. So these are the 3 important points why oral iron doesn't work. And that is why today the recommendation is that if you have low hemoglobin or ferritin is less or TSAT is less, then you must, number 1, do in all patients these studies and give this drug, especially if the patient is affording, and tell the patient. Now, later on, depending upon the ferritin values, whether to give them oral iron or not, if they can tolerate, you can give oral iron, depending upon, because normally once you give this drug, I have seen for at least 3 to 4 months, patients are okay, and they symptomatically improve significantly. So this is the first pillar, I would say, beyond 4 pillars, anemia correction, simple, treatable, and we must do in each and every patient. So this has to be done in all patients with heart failure. The next, of course, is Versuagat. You must know this here. We have looked at ARNI, RAS, SGL2, and beta blockers. Now, this is Versuagat is a guanylate cyclase stimulant. That means it increases the cyclic GMP. So different pathway. And what this study was important. So this is the second pillar again beyond the 4th pillar. This is important. The Victoria trial was interesting. It just recently published. They took patients with worsening heart failure with repeated admissions, so admissions within 6 months with heart failure. Okay. So increased hospitalization or increased diuretic dose or increased antiprobial. And patients who were eGFR, remember, between 15 and 30 patients were taken. So this is an important thing for that. And that is why today Versuagat is 2B, but now we have a new trial going on. The important point about this trial, you must know that it showed statistically significant decrease in the total hospitalization and mortality. Okay. And the important point is all patients high risk, remember, 60% were already on 3 pillars. Either beta blockers, MRAs, or around 15-20% were on ARNI, but the SGL2, all 3 pillars patients are already taking. So if you find now already in this trial, three drugs are already there. So you don't expect a very robust reduction, but still you found a statistically significant reduction. And that is why this is showing great promise for 2 reasons. Number 1, so today, just come into the market 2 weeks ago. I have used it in at least 6 to 7 patients, just started in 6 to 7 patients. The dose is 2.5 milligrams once a day for 2 weeks, 5 milligrams for 2 weeks, and 10 milligrams once a day later on. Now, the important point is, so how do I look at if the patient has repeat hospitalizations or the NT-proBNP is high? Now, again, there's the NT-proBNP value. More than 8,000 don't use. Less than 4,000 works very well. 4 to 8,000 it will work. Okay. So you look at NT-proBNP. If you have high diuretic dosages, I mean, suppose somebody is on furosemide 100 milligrams, okay, then you must start this drug. And I'm telling you, this will work. And there's a trial now which is coming up where, you know, they are not resistant or high risk patients, normal risk, whether you should use or not. And that will really change the way we are looking. So now, you know, we have 4 pillars. We have anemia correction. We have Versugat. The last one, which is not coming to India, is, but this is an interesting, again, interesting drug because it stimulates actin myosin without changing dP by dt. That means it doesn't consume energy. So the mechanism is that it improves your pump without consuming energy, increasing dP by dt. And that is why this drug is important. The important point about this paper is a trial called Galactic HF, where they actually compared, they took low EF patients. So less than 28% EF. And they also divided into 22, 22, 22 to 25, 25 to 28. And this was an important trial, and which showed that with low EF, this drug actually worked without increasing the energy consumption. So again, this is the last drug which has come. So now we have a spectrum. The first 4 are extremely important. Then comes anemia correction, which is simple and extremely important. We have Versugat, which has come. This has not come. So this is now we have a spectrum of drug which has really revolutionized the treatment of heart failure in day-to-day practice. The final concept of treating heart failure is what is called, let's see, remember ACE, ARBs, beta blockers, we talked about neurohormonal blockade. Okay. And then now from that concept, we have come to what is called comprehensive disease modifying medical therapy. That means we are looking at different mechanisms. Okay. We are modifying the disease at different levels. And that has really changed the whole way we are treating heart failure today. And it's amazing. The way we are having this response, we never had for several years. Kantare sir will tell us he has been treating for almost 35 years now. How the response was there previously when we had only ditched diuretics, and these are the only 2 drugs. And now we have a spectrum of drugs where we are going to modify. So the concept is we are not now trying to compare single superior pill concept. You know, last 2-3 years we were discussing SGLT2 first, ARNI first, how to go about it, which is better. That concept. We want synergism of multiple pathways. We want to modify multiple pathways. And the slide I showed you, all 5 drugs and 6 anemia correction are multiple pathways. So with this concept, now it is going to really change the way patients are being treated for heart failure, the way their symptomatic response to where the hospitalization is going to decrease and their mortality. So this is now the new concept of CDMT, and this is this. So here, just to tell you the last slide, that what they say when your patient is with heart failure, ARNI low dose titrate, SGLT2 initiate, beta blockers low dose titrate, MRAs low dose titrate. Within 1 to 4 weeks, all drugs should be on. Now this, remember, is what has been suggested by all the data. This should and can be modified depending upon the hemodynamics and your clinical discretion. The idea is that we want to modify all this, plus the last 3 which I have said, anemia correction and of course Versugat, which is now there, out of which, again, I am repeating, anemia correction is the easiest way out. But all this now is the concept of heart failure treatment, that please hit all the pathways at different levels and try to achieve decreasing mortality and minimum hospitalization and symptomatic improvement. So in conclusion, current medical therapy has revolutionized treatment of heart failure. There's no question about it. Focus on quality of life, hospitalization, mortality. That is the focus. We want to avoid ADHF as far as possible. Mandate to have 4 pillars on today. But we must look beyond 4 pillars, where anemia correction and Versugat, what we have today, is available and can be done. The concept of rapid sequencing and CDMMT. That means you want to go early and give all the modifying drugs at different pathways. And while doing all this, you must use all the scientific data and your clinical discretion. That's still extremely important. Please remember, Today, clinical medicine is, people think it's, you have to just do echoes and MRIs. That's okay. But your clinical discussion in a patient of heart failure today, I still feel is extremely important, even in the ICU setting and in your clinic. So use good clinical discussion to give optimized and personalized care to a given patient. So you cannot just go by data, okay, SGL2 in all patients. You have a problem, you give it the other drug. So we are going to initiate all these drugs at different timings, use good clinical discussion and see what you can do, give the best optimized treatment to heart failure patients. Thank you very much.
Talk about this syndrome of heart failure. As you had said that when the heart failure words are uttered, we always thought in the past that the patient is an edematous patient and with all the signs of edema and raised JVP. However, currently the heart failure is taken as having 4 stages. And even the stage 1 starts when the patient has got hypertension or diabetes or having an ischemic heart disease. And the treatment has to start with the stage 1. The heart failure starts immediately with an index event. It could be a myelin infarction or it could be any other, say, cardiomyopathy. Start the treatment for heart failure. So that is my first question is, do you start with immediately if the patient has got a myelin infarction? Do you start or wait till the patient develops some sort of a condition? And do you start with the diuretic or you start with the
Yeah, I think important this, the first point sir mentioned was that the stages, if you see the current classification, the patient with hypertensive diabetes is stage 1 heart failure. So the concept now is why this has come is that suppose you have diabetes, okay, or you have hypertension, you must start with SGLT2 today because these are one of the 4 pillars, beta blockers and diabetes. So if you are a patient, so depending upon the clinical subset, even with stage 1, so that was the concept of categorizing patient as stage 1. So at least give these drugs whatever possible at stage 1 to avoid future. Now, the second is patients with asymptomatic LV systolic dysfunction. Somebody comes to you, no heart failure, you say echo is 25%. What will you do? Yes, you initiate all these 4 drugs so that you avoid hospitalizations. That's number 2. As for third, as far as AMI is concerned, as I mentioned, acute AMI, beta blockers 1 is on, MRAs can be on. Okay. Now the only question comes whether remodeling occurs after revascularization within first month to 3 months. If you still find LV systolic dysfunction, initiate the others. So this is at different stages depending upon the patient and the clinical subset you have to initiate. But as sir rightly said, that stage 1 is hypertension, diabetes. So diabetes. So ideally today, now if you see even the ADA recommendation today, they are starting with SGL2, GLP-1 analogs and metformin today, and then all the others, DPP4 and all the others. So the whole concept is that at least try to use drugs which will eventually avoid development of heart failure. So depending from stage 1 to end stage, we have to give in different classes of drugs.
Second question is regarding the SGL2 inhibitors. Initially, when they came, only the Canadian Heart Institute or Canadian Heart Society, they gave it as a class 1 indication. What is the current status now?
Now it's class 1. So except what happened, SGL2 is class 1. In fact, the Americans, the ACC guidelines for ARNI is after SGL2. But ESC is same, class 1 for both. So ARNI, but today SGL2 is class 1 for heart failure.
Coming back to ARNI, ARNI actually it is the sacubitril is an inhibitor of neprilysin. So the neprilysin is known to decompose and degrade the natriuretic peptides, but it is also known to degrade the angiotensin. It also also the vasodilators. So when you start ARNI, there are many times some patients they respond with a very low immediate drop in the blood pressure. while there are some patients who just tolerate it. So how do you start with a small dose? Because you said in your lecture you would not like to start with a small dose. So do you start with a small dose and look for this, or you just start with it?
Yeah, it is absolutely subset dependent and BP dependent. See, the trials showed that your systolic BP should have been, paradigm showed that it should be above 95. So anybody whose systolic BP is more than 110, you can start with a bigger dose. But anybody with a systolic BP which is low, you must start with a slow dose. In fact, the CDDMT initiation was 50 milligram half BD also you can start. 50 milligram half BD, because where the BP, systolic BP is around 90, 95. Okay, so you start with a slow dose, a smaller dose. The article mentioned that if you start with a higher dose, which we cannot in almost 50% of patients, they rightly said, you cannot start with 100 twice a day. It's not possible. People become hypotensive. So start with a slow dose and slowly, and that to that response, you can look at the response of potassium, creatinine, and the blood pressure. Now, only thing is, suppose the BP is still not coming up, then you must look at that you are not having excess diuresis. That's number one. See, what commonly occurs is ADHF admissions, you have IV diuretics, then you give a high dose of diuretics. So look at your diuretic dose, look at whether your patients are nitrates or hydralazine, look at any other drug which can decrease your blood pressure, and then you look at the early dose. So these hypotensive drugs or factors should be thought of, and then you see the early dose. But yes, if the patient's systolic BP is 90, 95, then you go with a smaller dose, and then you can uptitrate later on.
Actually, heart failure is, as I said, it's a syndrome, and we started treating the manifestations of cardiac failure, like we started treating the pulmonary congestion, we started treating the systemic congestion. Now the disease modifying have come, because ultimately whatever you treat with the ARNI, you treat with the MR antagonists, you treat with the ACE inhibitors, it is not going to affect the ultimate progress of the heart failure. It's a progressive disease. But now the disease modifying drugs have come. So what do you think, that Vericiguat or omecamtiv is not yet available? So when we will start that?
The thing is, currently the data is for Vericiguat is only for repeated hospital in the high risk subset. But the new trial which is going on for Vericiguat is de novo patients. Because what you are saying is right. Suppose this particular drug can be given with a eGFR of between 15 and 30, which is amazing. And it doesn't touch potassium, sodium, and creatinine. Okay, so that is why perhaps, because there is no data, today we cannot, but again, this is going to come. That perhaps Vericiguat we may start earlier than other drugs also. But that time will tell, because that drug, the second trial is on for a de novo low risk subset. But eventually, yes, you are right, because we are modifying the disease. So perhaps the earlier we start these drugs, it may be better. But current data for Vericiguat is only for high risk patients.
Actually, the heart failure, as I said, is a progressive disease, and ultimately what causes is a myocardial failure. And ultimately, it's a myocyte which start failing because the mitochondrial metabolism is deranged totally. So that's how this omecamtiv has come, which without increasing the oxygen consumption, without increasing the dP by dt, it helps to actin and myosin to bind together. Is there any other, in this situation, would you like to add some device management in these patients, apart from the medicine?
Yes, if they're resistant and if the indications for device are then we use. But overall, now they have found with these drugs now, in fact, even the CRT implants have gone down. It's the other way around. That but of course, if you have a patient who has a broad cure is more than 160, then of course I would give the benefit of resynchronization in a different way. I would not wait. But otherwise, overall, ICD implants and CRT implants are coming down with the advent of these 4 drugs.
Any other questions?
That's what I think. In ADHF, the patient is on inotropes, and in the first 24 to 48 hours in the CCU, you should not start ARNI, because the patients are hypotensive and we are giving inotropes to have the BP up. So that is not the time to start ARNI, number one. The ADHF trial for ARNI, that means very early start, did not show mortality benefit. But yes, I would start After the patient is transferred to the ward, of IV diuretics, of inotropes, between pre-discharge to the first OPD visit, you should start early in a small dose. Pardon?
You see, sometimes you know, early half OD, 50 milligram half OD. But they do, patients do better, you know, blood pressure are borderline, mental historic, and then half OD also they do better.
Yeah, fair enough. I mean, see, there's not going to be any data on such dosages. It is not possible. You know, in general, in India, remember, for all the dosages, we are always suboptimal. Okay, but here in a patient with ADHF, because the data was negative for statistically significant mortality, I would still start in a smaller dose. So half OD, I'm not saying it is ideal, but as long as you uptitrate faster, it is still okay to start early than not to start early. But now you have other drugs. So, you know, I would start SGL2 immediately. Perhaps now somebody is hypotensive, EGFR low, I would start Versuagat. We have so many other drugs now, and then initiate ARNI. So here, that was the concept of CDMD. So you don't have to do everything pre-discharge. And there's no need to discuss, I mean, no need to argue on that or, you know, debate. I would like to my patient to, once your hemodynamics improve, you will be able to start ARNI over a period of 1 to 4 weeks. So you can initiate later. It does not matter that you have to initiate everybody pre-discharge.
In ADHF, as the one of the slides showed, that it has to you have to decide whether it's about the low BP or the patient is wet or patient is bad. Depending on that, the treatment would be to give diuretics, to give inotropes to make hemodynamics stable. And as early and desync are going to take time to start. And whatever the mechanism, if you see the mechanism, it is not a immediate action. The action is built up. So that has got no role in the ADHF patients in CC.
Absolutely. And 2, 3, I really don't know. I don't know the effect on these drugs. The whole thing is all these mechanics of heart failure, you know, they are at the cellular level. So it doesn't really matter as long as there is symptomatic improvement. But honestly, to the answer to your question, I'm not sure.
Sorry, I couldn't get the question. What was it?
Any other question?
Thank you, Dr. Sate, for a very good lecture. Let's give a big hand.
Thank you, Dr. Kadtari, for being here with us today. We'll move on to the next very important subset, that is anemia in CKD. And for this, I will invite Dr. Bale. He is a professor of nephrology in DY Patil. And thank you for coming. He is the chairman. And I'll invite Dr. Dige. We all know him, but Dr. Bale will just introduce him, and then we'll start the next session on anemia in CKD.
So sorry to interrupt you. Can you unmute your mic? Hello.
Prevalence of chronic kidney disease is very, very high. And in India, we are having huge number of chronic kidney disease patients. In India, we will have more than 140 million CKD sufferers. So we will become one of the major contributors of CKD to the world. Sorry. Anemia. So anemia in chronic kidney disease is a very, very common complication. If I show you the prevalence is very small in the initial period, but as CKD will progress, the anemia can go right up to 50-53% of patients with chronic kidney disease, CKD3 and CKD4. So what are the various causes for it? And ultimately, the causes will be multifold, but the commonest cause will be that of erythropoietin deficiency. Then there will be iron deficiency. We'll have uremia-induced inhibition of erythropoiesis. Then we have shortened RBC survival, and we have nutritional deficiency. So all these factors will work together and will cause anemia in chronic kidney disease. So why do CKD patients become iron deficient? First is because of increased losses. So the losses are occult GI losses, peptic ulcers, continuous blood sampling. We do a lot of blood sampling, and this is also associated with iron loss. There is a lot of losses during dialysis. On dialysis, at the end of dialysis, we'll try and return all the blood that is possible that has come out, but there still will be significant amount of losses. Then concurrent medications, for example, aspirin. Aspirin will cause small amount of bleed and the patient will become iron deficient. And heparin. Heparin itself will cause anemia. And then CKD related causes. Patients will have been nauseated, they will not eat, there will be poor GI absorption because of edema. And medications like omeprazole or pantoprazole will create problems. And interaction with food. So what are the consequences of CKD-related anemia? Increased risk of hospitalizations, cardiovascular disease, cognitive impairment, increased mortality, and TSAT of less than 20% is associated with more cardiovascular hospitalizations and mortality, which we just listened to. So how does anemia develop? First is erythropoietin, then comes iron, and then comes the production of hemoglobin, and then the hepcidin which is produced will block these iron production and then will reduce. Then will come the pivotal role of iron in erythropoiesis. Erythropoietin will work and act in 3 units, the CFUs, the BFUs, and the proerythroblast. And this is where after that iron level have to come up. So if iron is not available, erythropoietin is useless. So if you don't have adequate iron available, using large amount of erythropoietin will have no role. When do we, and what are the various tests to be done? The KDOQI guidelines, very, very stringent. But what we usually want to do is complete blood count, absolute reticulocyte count, serum ferritin level, transferrin saturation, serum vitamin B12, and folate levels. So how do we judge iron status? We do serum ferritin. When serum ferritin is less than 100 micrograms, we call this iron deficiency. When we have hypochromic red cells, we call this iron deficiency. We have transferrin saturation, which is less than 20%, iron deficiency. And when serum and total iron binding capacity, the iron levels of less than 65 in male and less than 90 in females, and total iron binding capacity of more than 425 is iron deficiency anemia. So these are the few lab diagnoses which we listened to in the first talk. But iron deficiency, we have iron which is low, transferrin saturation which is high, the transferrin saturation which is low, and the ferritin level which is low, and this becomes classical iron deficiency. So why do we want to create, or why do we want to treat anemia? We want to treat anemia because the anemia will cause increased risk of left ventricular hypertrophy, myocardial infarcts, and heart failure. Hemoglobin level less than 8 is associated with increase of odd of death in more than 10 to 11. So if you have hemoglobin less than 8, we have much more chances of mortality. Correction of anemia will bring about partial regression of left ventricular hypertrophy in patients with end-stage kidney disease. And of course, it will increase the energy levels and expertise capacity in CRF. And anemia correction will also improve cognitive performance. What are the treatment options? First is iron supplementation, then is ESA, and then blood transfusion. ESA is erythroid stimulating agent. Types of iron deficiency, they will be in CKD. We have one which is absolute, where the iron stores are low, and there's one which is functional, where there is iron cannot be mobilized from the stores. So what are the things that we look at? Anemia, hemoglobin low, we have to replace with iron, but we also will have to look at the red blood cells which are hypochromic, the iron which is depleted, and then we have to keep on repleting the stores in this fashion. What are the various oral iron salts? I think we took it in the first slide, so I'll not go ahead with this. What are the KDOGI guidelines that we have? I'll go slightly more details. Iron therapy. CKD with anemia, they should all be treated with iron and ESAs. And IV iron is associated with increase in hemoglobin and decrease in ESA doses is desired, with TSAT which is less than 30% and ferritin level which is less than 500 grams, we should treat with IV iron. And patients who are on ESAs but do not have iron, we should have IV iron replacement once trial, or replace the test every 3 months and find out what happens with that. Then iron monitoring, we should be doing TSAT as well as ferritin levels every 3 months. And there are precautions for IV iron therapy, which we'll discuss slightly later. So what are the various IV iron preparations available? There are multiple generations of IV iron. The first one, the iron dextrans. The second one is ferric gluconate iron sucrose. And then comes the ferric carboxymaltose. In 20 years back, we have all used iron dextran, but now we are not using them. Iron sucrose and ferric gluconate, they will be. So what are the various problems with these? Iron dextran has got serious allergy reactions and joint pains. So we have had the bad experience with that, and we are not using them right now. Then we will be using the ferric gluconate, which is approved only for hemodialysis, but the dosages that can be given are low, and so multiple hospital admissions will be required. Same thing goes with iron sucrose, because the dosages that we can give are low, so multiple injections will be required. And it also has high labile free iron release, which is associated with more amount of hypersensitivity reactions. While iron carboxymaltose has maximum allowed single dose, and it has got much less chance of reactions because the free labile iron is less. So these are the properties of ferric carboxymaltose. It is a robust drug, low molecular weight. It has got very high complex stability, and it has got high half-life, pH neutral, and it's an isotonic agent. And time for preparation is small, and you can give maximum high dose. The dose can be given up to 1000 milligram can be given as a single bolus. So fewer clinic visits will be required and test doses not required. So how does it work? When you give intravenously, the bone marrow will take it up from the macrophages. Then iron will be released from there. Released iron is either taken by ferritin or through transferrin, and from there it goes to the erythroblast and the bone marrow, and then they will be incorporated into your hemoglobin, so your RBCs. Are there any clinical studies? Yes, there are a lot of studies. FIND CKD is the randomized trial in CKD. And what they showed is that as compared to oral iron, IV FCM targeting a ferritin of 400 to 600 quickly reached and maintained the hemoglobin level and delayed and reduced the need for other anemia management, including ESAs. So you can even reduce the dose of ESAs with good iron supplementation. Another trial, which also had similar results, overall FCM was well tolerated with minimal risk effects. Are there any Indian data? Yes, there is an Indian data available for this, where they had used it in chronic kidney disease, and they showed a very good response and very mild to moderate adverse drug reactions. So what are the indications? The indications is iron deficiency in adults who have intolerance to oral iron or had unsatisfactory response. Now, what are the maximum dosages that we want to give? Ideally, we should calculate the required dosages. Intravenous bolus injection can be given with FCM. We can give a single dose of 4 ml per day, but not more than 3 times per week. And intravenous drip infusion is usually given, but not exceeding 0.3 ml of ferric carboxymaltose per kilogram of body weight of calculated cumulative dose. And we will not give more than 20 ml, that is 1000 ml of iron, more than once a week. In hemodialysis dependent chronic kidney disease patient, the single maximum daily injection of 200 milligrams, and pediatric population, sadly, we don't have much of a data available. So what are the drip rates and what are the drip formulations? We have 2 to 4 ml, that is 100 to 200 milligram in 50 ml, then 200 to 500 in 100 ml, and 500 to 1000 ml in 250 ml, given over a period of minimum of 6 minutes and 15 minutes. But I usually give it slightly slower. I usually give 1000 milligrams in about 250 ml of normal saline over a period of at least 1 hour post dialysis. Dilution plan, we should use normal saline only, and each vial is single use only. So do not use multiple uses of the same vial. Once the vial is open, it should be used completely. So all these ions can have some amount of hypersensitivity reaction. So it is always better to be given where facilities for resuscitation are available. So better not to give it in a OPD office situation. Now, when the patient has active bacteremia, we should not be using oral, we should not be using IV iron treatment, because that can be associated with increase in risk of fungal infections. So adverse reactions are hypersensitivity reactions, some paresthesia, hypotension, flushing, some amount of vomiting, pruritus, urticarias, and in liver dysfunction, there is some amount of increase in ALT as well as GLT increase. But in practice, I personally have not found them anyway significant. Drug interactions. Drug interactions is not really very, very significant. Overdosages of FCM are associated with hemosiderosis, but as a whole, I'm not sure whether we have actually used that much amount of dose to create hemosiderosis. What are the other options available for treatment of anemia in CKD? The ESAs. There are 3 generations of ESAs. The first generation, which is epoetin alpha and beta. Second generation, which is darbepoetin. And the third generation is continuous erythrocytes receptor activation. All 3 are available in the market. All 3 work the same signaling mechanism. There are some investigational EPO dimers and EPO mimetic peptides are also available, but we have all the 3 earlier one, epoetin alpha, epoetin beta, darbepoetin, as well as Sera is available in the market, work equally well. So when to start? In CKD, we start with if the hemoglobin is less than 10 gram% and iron is repleted, then we should be starting EPO for these patients. So what are the contraindications of EPO? Hypertension, which is not controlled, we should not start erythropoietin. Patient who has got pure red cell aplasia, allergic reaction to erythropoietin, known hypersensitivity, and we should not be using multi-dose vials. Have not really used significant in many patients. We are now getting the single dose injection. So multi-dose vialing is almost unheard of, but maybe the oncologists have used multi-dose vial more often than we have. What are the warnings? Warnings are that of thrombotic tendencies, myocardial infarction. Adverse reactions are very rare, but hypertension, arthralgia, pyrexia, pregnancy, nursing mother, neonates and infants, we should not be using them only when it is clearly indicated. What are the newer advantages of newer advances? We have something called as chronic inflammation, which will suppress the erythropoiesis. And so we have the hypoxic inducible factor. This hypoxia inducible factor will improve the erythropoiesis. And then there is an enzyme called pyrrole hydroxylase, which will block this hypoxia inducible factor. So oral medicine, which is hypoxia inducible factor pyrrole hydroxylase inhibitor. So HIF, PHI are the ones which have now come into market as the oral replacement of ESA. The only one company is there in India, which is having a medicine called roxadustat, and which we have started using in patients with chronic kidney disease, and the results are fairly encouraging. So this is absolutely the newest availability in treatment of anemia in chronic kidney disease. So key points for practitioners: workup for anemia for CKD should include assessment of mandatory of secondary causes of including iron deficiency. Iron replacement is often effective in anemia of CKD. Then ESA, we should look at the few contraindications of ESA: active malignancy or a recent history of malignancy or infections. And we should aim at hemoglobin between 10 to 11. We should not be aiming at hemoglobin of more than 12.5. So EPO cannot be used to give hemoglobin more than 12.5 because then it is associated with increased mortality in chronic kidney disease. And in pediatric population, it's a separate one. Which ESA is to be initiated is to be individualist decision, taking into potential benefit. To summarize, iron therapy, blood transfusion, ESAs are mainstay of treatment in renal anemia. Inconsistent and inadequate absorption of oral iron frequently leads to administration of administration of intravenous iron. And FCM has good characteristics of iron dextran, but is not associated with dextran-induced hypersensitivity. It can be used at a much higher dose than iron sucrose and iron dextrose and iron gluconate. Up to 1000 milligrams can be given in a single dose. Oral HIF propyl hydroxylase inhibitor is a new therapeutic option, but long-term studies are still awaited. Thank you.
Thank you for lucid Dr. Pratik. I just had one practical question. So what will be using iron supplement or the oral iron supplement?
In chronic kidney disease patients who are on maintenance hemodialysis or on peritoneal dialysis with lots and lots of nausea and abdominal discomfort and the patient not eating well, oral iron increases the pill burden, is associated with constipation. And so I almost always prefer to put the patients on IV iron in. But my practice is very specific. I look at only CKD with dialysis or other. Otherwise, the classical indication of IV iron is those patients who are not tolerating oral iron or are not having adequate response to oral iron.
Heme polypeptide or lactoferrin combination?
Heme polypeptide and lactoferrin are slightly better than the other previous in form of causing less amount of nausea, less amount of constipation. And so that's why sometimes when in patients with OPD patients with chronic kidney disease who are not going for IV iron therapy, I do use heme iron polypeptide. Yes, Vijay, I use it.
And the question is, what will be your maintenance treatment for anemia and
The
dialysis?
In dialysis dependent, we will aim at a hemoglobin of 10.5 to 11.5. So I would stop the erythropoietin supplementation when I get the the hemoglobin level of 11.5. I'll keep on monitoring it. Usual dose of starting erythropoietin of erythropoietin alpha or beta is 100 to 150 units per kilogram every weekly till we achieve a dose, till we achieve a hemoglobin of say 11.5, and then I reduce the dose to a value of say about 4,000 units or 6,000 units every weekly till and then maintain that dose. If the hemoglobin keeps on rising, then I will not continue erythropoietin. I usually stop. And for iron, I will keep on looking at every 3 monthly TSAT as well as transferrin saturations, and then decide about IV iron therapy. It's not worsening renal function, but patients who are on dialysis have increased risk of vascular access thrombosis. They have increased risk of stroke and increased risk of even myocardial events with hemoglobin which is more than 12.5 to 13. So I usually will stop my IV iron as well as erythropoietin supplementation and keep my patient's hemoglobin between 10.5 to 11.5. Correlation between, I had a question, failure as well as renal disease. That's now ketogenic towards heart failure, and I don't know whether there's some data in renal failure. In the renal failure, we will the low carb, high protein and high fat diet we are not using, because high protein diet is always associated with increased amount of nitrogenous waste production, which needs to be excreted by the kidney, and when the kidneys are working less, the expected protein intake for chronic kidney disease patients not on dialysis has dropped down from 1 gram per kilogram to 0.6 to 0.8 gram per kilogram. And so for patients who are not on dialysis, definitely no low carb diet. Patients who are on dialysis, on hemodialysis, we increase the protein intake to about 1 to 1.1 gram per kilogram, and patients on peritoneal dialysis, we increase the protein intake to about 1.4 grams per kilogram of body weight per day. But personally, I do not advocate the low carb, high protein, high fat diet for my patients.
How many patients are on erythropoietin overall?
OPD patients on maintenance, patients who are on maintenance hemodialysis patients, at least 65 to 70% patients are on erythropoietin. Rest who are not are probably because of financial reasons, because we always advocate erythropoietin therapy to all patients on, because that will reduce the number of blood transfusions for our patients, and then they will be better, the chances of sensitizations will be less, and the patient will be better prepared for transplant. So we are not really very happy to keep on giving blood transfusions to our patients, but dialysis is a big expense, and our patients, all the patients may not afford that, especially the patients who come with scheme and patients come with government assisted programs. They usually go ahead with dialysis is provided by the government, but erythropoietins, they usually cannot afford that.
What about your CKD 1, 2, 3? I mean, not dialysis, and you look for In all patients, what you do? What is your protocol?
Patient who presents with hemoglobin less than 12, 12.5, which is anemia, and patient has CKD, then I would look at the iron status at my first or second visit. And then depending upon the iron status, I decide about oral iron therapy. By the end of 6 to 8 weeks, if I have not got adequate response, then I would consider IV iron therapy for this patient.
Dr. Ramanan, for you, your normal patient is anemia. So somebody will be so are you going to do ferritin in all patients, or you can start oral therapy without doing ferritin? He said, and forget heart failure. Huh? Normal patient.
I would look at the ferritin, and if ferritin is the cheapest of all. So, and if the ferritin is low, less than 100, starting, the man cannot afford anything. Those I would investigate. Because
all anemia should have ferritin level.
Absolutely.
Normal anemia patient.
Yes, because we don't know the reason of go and treat it as such. And anemia, as Dr. Bhave also said, it's not a cause. So we need to find the cause also, because that could be that could have a nefarious.
But the common practice is, suppose somebody's hemoglobin is 11, some form of oral iron. Is that right or wrong?
We have to remember that iron is not it's a double-edged sword ultimately. Hemochromatosis, ultimately, iron surely gets accumulated in the body also. There are few patients who get to a high ferritin level. So if you have a patient with STAT minor, for example, you keep on giving iron, he keeps on storing it because the hepcidin is suppressed for a longer period of time. So it's not a good idea to give. What we feel is that, at least in our practice, we feel the patient comes in with anemia, and we know that this is iron deficiency anemia looking at the blood picture, hypochromic microcytic. If it is clearly hypochromic microcytic, we will still consider not doing any test and start him with oral iron. But the patients with chronic kidney disease the anemia is twofold, the iron deficiency anemia as well as anemia of chronic disease. And we might have the normochromic picture also on the peripheral smear. There, we would want the iron status to be done. And depending on the iron status, we will decide about oral, as well as if oral is not helping this patient in 6, 8 weeks, 12 weeks, then we would go ahead with IV iron. Nowadays, it's become very, very comfortable. Like 1, 2 hours, 3 hours daycare admission, and the patients are happy not taking, because I'm already giving him 3 antihypertensives. I will be giving him some drugs for calcium, some drugs for phosphorus, some drugs for uric acid, and then I reduce 2 drugs for 2 tablets for his iron. Patient is happy to take 1 injection after every 3-4 months. I had few patients where wasn't done. Ferritin came out to be like 400, 500, and we just investigated for lead poison. It turned out to be a lead. So microcytic anemia at that time, if you have a high ferritin, just think about lead, because many of the patients think Ayurveda has side effect master, but ultimately they keep on taking because it's freely available. So lead is one of the things which we need to keep in mind, because it can cause nephropathy, it can cause 1,000 other things. So microcytic anemia, if your ferritin is high, thalassemia minor as well as lead poisoning has to be kept in mind.
Patients overall, general public,
90% are nutritional, and I would say 10%, because probably the blood loss fellows are with the gastroenterologist more than me, and or with the nephrologist, because they're dialyzing them. So 90% are nutritional.
what is the threshold for when should a normal physician what is the threshold when should you
Patient. Yeah, they should at least do a ferritin, I feel. And happening now is they're starting the oral line, they're waiting for 3 months and then referring to us. So probably they can wait for a month or so. If that doesn't improve, they should send. But there are many other things which anemia is not as simple as it looks. So out of 100 anemias, probably 10% would be a plain iron deficiency, but there are other diagnoses which we could make. I usually say that.
Let me say what is in your practice for anemia.
Depending on the MC, it's low. And if your ferritin is normal, then you look for calcium. If your ferritin is low, your T cells are low, of course, give them iron. And on follow-up, you look for that not responding enough. Then people do it.
So threshold of any PCD. For anemic, severely anemic, maybe.
That he's got hypertension, he's got a cardiac event, he's got a renal, then my target would be higher. I would rather maintain 8 and 9. Otherwise, from an elderly guy, I would maintain 7. That's good enough. But I have had my nutritional people at 2 and 3 grams also, we have gone away without transfusion by supplement. Simple iron deficiency anemia, the best part of dropping, the whole hemodynamics starts improving. The 2-3 DPG level changes according to nature is a beautiful thing. So these people have a very compensated heart. So we need not go and jump and give it transfusion. I look at the heart rate first. The heart rate is doing fine. The person is not on a beta blocker. I would just wait for the thing to work. Probably 2-3 weeks down the line, if they improve dramatically. Young guy, I would wait.
If your hemoglobin is less than 8, that is correct practice or wrong practice?
Absolutely wrong practice. So every blood is agent. Luckily, we get more blood now than 10-15 years back. HIV is still there, B, Hep C, everything is there. So giving blood would be my last choice.
So I've got a question. Serum ferritin, we want that is an acute phase rate. Anemia patients will be advised ferritin for each and every patient. And if this patient has got some kind of low-grade inflammation and serum ferritin is not on higher sensor, then how should we approach it?
Yeah, we had it in the first lecture. There's a test called soluble transferrin receptor. We started using it. Soluble transferrin receptor by log of ferritin. You get whether it's anemia chronic disease versus iron deficiency. It's greater than 1.36. It's supposed to be suggestive iron deficiency. So simple test is soluble transferrin receptor. If a patient cannot afford, I think look at the TSAT. If the TSAT is less than 20 or 30% in nephrology, you can go and give the iron. Right? I mean, what your month of iron will not harm him as such.
Secondly, sir, severe anemia cases when the hemoglobin is less than 6 grams, should we straight away start with the PCD for the patient? Same question, what's the I guess?
No, I would say we should look at the full picture rather than the number. The number doesn't define anything. The patient tells us more. If his hemodynamics is stable, I would just wait because the blood can cause more harm. Trally, PH, GVH, there are so many side effects of blood that I would not like to transfuse upfront. I don't do either.
And so, one question for the user. One of the slides was just in case of using ESS, there is a risk of having thrombosis. So, in patients having heart failure, last subset of patients have got heart failure as well as chronic CKD. And these patients having hemoglobin of around 9 or 10, what we should do?
9 or 10, I would just use IV, oral and IV iron, keep the TSAT and ferritin up. I will not use erythropoietin in this patient. If the patient is not having CKD on dialysis, but in dialysis also my cutoff point where I would start erythropoietin for a patient with CKD, with patient is on maintenance hemodialysis, is hemoglobin which is less than 8. That is the point when I would start. If the patient is reasonably stable and maintaining well with hemoglobin of 8-9, I'll just keep his iron levels up, and I'll hope that the whatever erythropoietin is being produced by the kidney will help him maintain the substance rather than.
So in this heart failure cases, then what?
Heart failure patients usually with
less than 8, hemoglobin of less than 8. Then we will not be using ESS, right?
In heart failure patients with hemoglobin less than 8, I would replace the iron and I would use erythropoietin. Patient is already on antiplatelet agents in any way. So I would wait. There is a risk of thrombosis, but keeping hemoglobin more than 9.5 is going to help his heart failure better than taking that and not taking the risk of using erythropoietin. No, no. As the hemoglobin will goes up, the erythropoietin will definitely get better.
Still the viscosity, because the cutoffs for a normal person without renal failure, the hemoglobin goes above 12, they say stop it because thrombotic episodes increase. And in anemia of chronic disease, the guidelines are according to the EPO levels, and we use up to 450 unit per kg.
Our thing is much lesser, 150.
There's an element of deficiency there. In patients with anemia of chronic disease, there's a resistance to the EPO. So you have to go to
We have patients with transplant who post-transplant develop post-transplant erythrocytosis. Their hemoglobin goes up to 17, 18, 19, 20. So we then gave them therapeutic blood lating. The therapeutic blood donations are done to keep the hemoglobin below 16. So that is what about 20% of our successful transplant patients after 4, 5, 6 months will come back to us with erythrocytosis. Their hemoglobins will keep on going up, and there one way to use is use small dose of ACE inhibitor or ARB to just reduce the erythropoietin production by the new kidney, and second thing is to do the therapeutic blood donations for these patients. So the opposite spectrum, once the patient is on dialysis with hemoglobin of 7, 8 and then post-transplant hemoglobin of 17, and we have to do blood donations for these patients.
It's to create iron deficiency. What do is create iron deficiency?
What is the upper limit of hemoglobin where I should prefer?
That's your new guideline. The previous one was 17.5, and adult ladies.
Check.
So first thing we do is the erythropoietin level itself, if it's suppressed or not, and we do. Yes, you do a renal. I mean, we do a abdominal ultrasound to see if there's a hemangioma, which can secrete erythropoietin. If other symptoms are there, you do an MRI of the brain for the cerebellar hemangiomatosis.
Positive, somebody is hemoglobin 70.
Around 20% to 30% would come for a myeloproliferative disorder, and you have to look at the other numbers also. The platelet count is high, the WBC is high, all those things fit into the whole thing. Very low, then you should do a JAK2 mutation, which is, and then there are drugs to prevent the same.
Suppose somebody is diabetic with a high hemoglobin, suppose you investigate.
It depends on the more than the hemoglobin. If he's had an episode of thrombosis, no episode, then I would not put him on because the primary prevention data is not very great with aspirin.
In such situations, would you think ACE inhibitor or ARB will work?
I don't know. There's looking interesting data there.
What is the
4.5 lakhs is my cutoff, and common reason in India for thrombocytosis. Secondary thrombocytosis is more common than primary thrombocytosis. So first deworm. Dr. Bhave said you would deworm intermittently, but that ferritin and deworming is my first act. Then I would start investigating. So history is very important. Thrombosis is important.
Just taking you off anemia. The hypertension in CKD. What are the 1, 2, 3 drugs you are using? They come to us, they come to you, and
they're
which I think is
Cilidipine is very weak. Very weak. Very weak.
What is the drugs which you like?
So most of the nephrologists, why they love ciltapine is one is a weak antihypertensive and the antiproteinuric effect.
This
Those are the two.
a slight antiproteinuric effect that it has more than amlodipine. Yeah. Amlodipine is the best. Amlodipine and nifedipine.
So what else would you use?
I'll think is less than 40 and more than 40 of each. If it is more than 40, I start with CCBs and beta blockers and rest of the that is alpha sympathetic and alpha blockers. If it is less than 40, we go for first thing will be the ARBs or ARB and then the rest of the things will follow.
Does ARB, when you are dialyzing a patient, why can't we use?
We do use ARBs when the patient is anuric. When the patient is having chronic patient is on chronic dialysis, and if the patient is producing some amount of urine, more than 500-700 ml per day, then that amount of renal function, that amount of glomerular filtration rate is allowing us to reduce the dialysis frequency. It is allowing us to increase the fluid intake for this patient. And it is so that's why we will want to preserve the residual renal function as much as we can. So no, I would no. In that, once I use ACE inhibitors and ARBs in these patients will have decline in the transglomerular pressure, and these patients' GFR will fall. So this is the point where I would control the blood pressure with high doses of CCBs, then centrally acting agents, and dialyzing them better. 90% of hypertension of chronic kidney disease on dialysis is salt and water retention. So salt and water retention, you remove it with good dialysis and the patient's blood pressure does come under fairly good control. And then there will be 20% patients who will high renin hypertension, where we'll have to use the anti-renin agents. So anti-renin agents, beta blockers, as well as ACE inhibitors and ARBs, the ones which will, and then these, that is the point when I would use 75-80% patient, 90% patients are volume dependent. No, it is our job to prescribe. It is our job to decide what kind of dialysis that the patient is given. We should be looking at patients' salt. If I go to round on dialysis unit in my thing and find 5 patients with high blood pressure, I will scold my resident there. Why have you not managed the dialysis well? Sodium reduction, water removal, then temperature, saying that is all the tricks that he should use to try and get the blood pressure under control. So blood pressure control, dialysis works really, really well in chronic kidney disease. And then those 20% patients who have intradialytic hypertension, then this is the point where I would use anti-renin agents more often. But if the patient is anuric, I will be more comfortable. If the patient is having good urine volume, I would still be apprehensive for using it. I do use it, but I'm apprehensive.
So I'm going to ask that question. In your practice, are you keeping Orlan alternately or once a day, and for which patient and why? With this new data, important, all physicians should know. If it is alternative, it's very good actually. So I don't know. What do you do?
We basically, it depends on what Dr. Bhave also said. The amount I was giving to everybody. Now I give once a day to everybody, and if they don't tolerate, then go to alternate day as such. But I somehow
people I think mentioned alternate is better.
yes, so because it doesn't spike the hepcidin. So that was one data. So that's also
There's no recommendation in your guidelines.
no recommendation. That single paper, it was published at ASH, American Society of Hematology. So it is a nice paper, good thought process as such. So we should ideally do the hepcidin levels and then see if it's hepcidin gentlemen, then we should probably think of giving alternative. See, the indirect effect of that is if a person has a lot of GI side effects, that means the person is making more of hepcidin. You can go alternative on that person. So unabsorbed iron in the intestine causes all the diarrhea, constipation, mostly in the ladies. So these are the people or groups, subgroups I would go alternative.
Is that right for listening to go?
Absolutely.
Daily versus alternate.
Yeah, I mean, probably companies will not be benefited by the alternative, but the industry will not do it, but people should do it.
For cardiologists, presuming about anemia, what give me names of 1, 2, 3 drugs which are the best iron drugs? No, say Siderum, Whisper XT, I don't know. Means Livogen, which is that has the least side effect. Seriously.
Definitely works well for
One supplement is better than the other.
yeah.
From all these, so many companies come first. So what is the truth?
The truth is, if the amount of iron that's getting absorbed from the whole compound, let's say 300 milligram, 20% gets absorbed, the 80% is going to cause a side effect. Ferrous sulfate, what used to happen is 2 to 6% used to get absorbed, and the rest used to cause side effect. Heme and polypeptide, initial data set 50-60%. So we really don't have randomized studies to say that. But any protein which is added, like the polypeptide which is added, allows heme per se. Animal proteins get absorbed much faster than inorganic things. So if you ask me truly, theoretically, heme and polypeptide would probably get more absorbed than the others. And the form of the tablet is also very important, because if you have a size tablet, there are many people who will not be able to. Second is heme and polypeptide. Third,
Three, four names are there. There's Nutrasur is there, which we use.
Yeah, Nutrasur was there for
quite some time.
For some time, and
Nutapex is there. Then Polypex, Nutapex are there.
And third is Orofer XT itself, or Whisper XT, whatever. So that, and I would rather give the Orofer XT or Whisper XT alternate day only, because there are a lot of iron in it. The hepcidin will surely get spiked. So if you have to give it, it's a large size. I mean, you try to consume that tablet.
Heme polypeptide is 12 milligrams only. The iron, total iron is 12 milligrams only. But they say that it is 70% absorbed. If you give 100 milligrams of iron, which is 10% absorbed, the absorption is 10 milligrams. Here, 12 milligrams and 70% absorbed, the absorption is almost the same. And the side effects will be, as he said, the iron which remains in the gut will cause side effects. So maybe much less.
Doesn't harm. It's water soluble.
So water soluble.
It goes away. There's no syndrome of folic acid excess that I know.
On the oral irons, the salt, which is ferrous fumarate, is followed by ferrous sulfate, followed by ferrous gluconate. Is it should be salt? I don't know. Ferrous succinate is another salt. Benefited by this things. It's not simple. It's important. Like Dr. Raman said, is lead poisoning based upon the microcyte efforts chronically. My history patient has given history of lead exposure, occupational history, whether he's working with the environment. Similar critical examination, if you find it, both favoring lead poisoning. Basically, stippling in peripheral blood towards the lead poisoning. So it is a totally the
In microcytic anemia, and
Doing it blindly for everybody will not work. It was like as acute phase reactant. A good report nowadays, most of the laboratories will give the cell counter reports, and the reports are very good. They are like, they will give you a lot of information which, as a super specialist, we usually do not need, but that information is there for us to.
Pre-analytical variables, as Dr. Bhavi had that case where he had a plot in the queue. Everything else is
very good reports we get of hemogram and CBC. Excellent reports these days we have.
I have hardly seen any CBD patients.
No, sir, there are patients. I I have one CKD patient whom I send for blood donation every two. Very rare, very rare. JAK2, everything has been done. Everything is negative. Nine is, it is CKD is a bad subset. CKD in cardiology involved in CKD is always a bad situation. Nothing like prevention, sir. Nothing like prevention of CKD. No, nothing like prevention. Control of blood pressure, control of blood sugar, control of cholesterol, and pray.
But we hardly pay attention to the red cell distribution. The microcytic hepatocyte can actually is there. Iron is rules of all other medicines. So like that, it is certain finding points in hepatic hemogram. Like it is because I want to learn anyway.
Same here.
I request Dr. Sate sir and Kattare sir to come on the stage. All the esteemed faculties and delegates, we are at the fag end of the first this CME on the focus on anemia and heart failure or the other complications. At the end of this meeting, I request Mr. Kuldeep Sharma sir, who is Senior Director of MPR Pharmaceuticals, to have the vote of thanks.
Good afternoon, faculty, and good afternoon, delegates. A small story before I will really get into the formality of vote of thanks. I think around a month back, I was having a discussion with Dr. Sathe. I represent actually the cardiometabolic segment of the MCure Pharmaceutical, which mainly known for the gynecology and anemia eradication, so iron therapies. Our name MCure is known mainly by the Orofer. Orofer is like a trademark for us. So we always take pride. I mean, MCure means Orofer. So I represent here cardio-diabetic segment of the business. So I was having a lot of discussion with Dr. Sathe. I mean, after a lot of evidence, I am only considering as an outside agent in the entire company. Because when it comes to gynae department, I mean, our divisions, they are doing well. When it comes to nephro department, they are doing well. When it comes to onco department, they are doing well. But why after so much evidence in cardiology and metabolic, we are not able to really do well? So sir said, I mean, it need a composite dialogue on, I mean, entire anemia rather than only iron deficiency in heart failure. I think around a 1.5 months back, sir. And I must tell you, I mean, as a custodian of the iron therapies in my respective company, it is one of the composite dialogues, sir, in recent time I have seen, where I mean different aspect of the anemia has been discussed, deliberated, and really, I mean, interaction was in last half an hour of very high quality. I am sure the delegates who have attended physically, and I have come to know from my team that almost 350 delegates are there online also, because this is a hybrid program. So, I mean, they must take back some real good messages for their clinical practice. As a company, I mean, we have definitely moved along with the industry only in different agent of the iron, which Dr. Ramana was also mentioning. I think around 2 decades back, it was a very different kind of the anemia treatment that we all used to have, I mean, the options. But today with the iron therapies, like which are much lesser side effect, better absorption, and most importantly in the injectable iron, I mean, therapy has really expanded up to all the specialty. And today the galaxy of faculty who are sitting here of different specialty speak about the volume of the impact of anemia in our patients. Can I say this, sir? I mean, with the respect of your permission. So, I mean, I'm really thankful, Dr. Sathe, and I could really understand the most anxious person to know about the anemia was you only, because maximum question was coming from you. But I think they must have benefited all the, I mean, delegates, offline and physical. On behalf of company, I can tell you, I mean, we are the largest anemic, anti-anemic player. As a company, our tagline is Anemia Free Bharat. That is how we basically play across. And today, if you really see, we are the biggest player in the anemia management in India, whether it is injectable, whether it is, I mean, oral formulation. From the initial oral formulation to the latest one, all the preparations we are marketing. Orofer is a leading brand, top 30 brand in the Indian pharmaceutical market. And I think that speak about the volume of the prevalence around 60 to 70%. And that we have seen across all the specialty. So in cardiology, obviously, I mean, which is the area where I am dealing with, and a lot of physician got the patient of heart failure, I think it's still underutilized resources, which Dr. Sathe will agree with me. I mean, need to be really, I mean, taken to the next level. So my sincere thanks, I mean, Dr. Sathe and all the faculty that you have given us a chance to really, I mean, take it to the next level, where, I mean, the faculties have of different specialty has given us a insight into the way forward for our clinical practice. So my sincere thanks to Dr. Abhay Bhave, Dr. Vijay Ramanna, Dr. Sathe, Dr. Anil, Dr. Tushar Dige, and Dr. Charan Bale on behalf of Emcure Pharmaceutical. At the same time, on a Sunday noon, I mean, or Sunday morning, I mean, sparing your family time and giving this time to hear, physically attending the program, or the audience who are there on the virtual platform. My sincere thanks to each one of you. And I will request now, I mean, please join us for the lunch. Thank you very much. Thank you very much, sir.
Nirav. Hello. RX events.
Yes, sir.
We can stop now live streaming.
Okay.